Welcome to the conference session titled Transplant for MDS. Thank you for joining us. My name is Nyari Sideo, Patient and Professional Programs Coordinator, and I will be moderating the presentation today. As we get started, we recognize the generosity of the corporate sponsors, as well as the generous support of patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. If you are participating online, feel free to submit questions at any time during the presentation from the Q&A icon in the engagement panel on your right. To submit a question, type your question in the Q&A text box window, and when you have finished typing your question, hit enter. We will do our best to get to all questions. When asking questions, I respectfully ask that you do two things to help me manage the incoming questions. First, that you submit your entire question all at the same time. Second, that you please do not share private health information in your question. Our speakers cannot answer any specific questions related to your healthcare. Today's specialist is Dr. Ryotaro Nakamura. Since joining City of Hope in 2002, Dr. Nakamura has been at the forefront of leading-edge research in stem cell transplantation with the focus of immune reconstitution and graft versus host disease, GVHD. His clinical and research expertise extend to leukemia and bone marrow failure syndrome, including aplastic anemia, myelodysplastic syndromes, MDS, and other rare diseases such as paroxysmal nocturnal hemoglobinuria, PNH, and large granular lymphocyte, LGL disease. Among his promising projects, developing vaccines against cytomegalovirus, CMV, and COVID-19 for transplant recipients, novel immunotherapy and bispecific CMV, CD19 CAR T cells, new therapy prevention of GVHD using microbiome-directed therapy. He has led a national study of older patients with MDS to compare survival according to donor availability and define the role of stem cell transplantation for this group of patients in a study called NCT 02016-781. Dr. Nakamura trained in Japan and served in a fellowship in hematology and oncology at the National Institutes of Health in Bethesda, Maryland, before arriving at City of Hope's Hematologic Malignancies and Stem Cell Transplantation Institute, which includes the Center for Stem Cell Transplantation, Judy and Bernard Briskin Center for Multiple Myeloma Research, Tony Stevenson Lymphoma Center, and CARE Family Center for Leukemia Research. Dr. Nakamura serves as the director of the Center for Stem Cell Transplantation and is the Jan and May Siegel Professor in Hematology and Hematopoietic Cell Transplantation. With that said, welcome, Dr. Nakamura.
Thank you so much for the very kind introduction, and I'd like to thank the organizers and in the foundation, the Aplastic Anemia MDS International Foundation, for inviting me to join this wonderful in-person meeting to go over the current updates and some basics of the diseases of interest, the aplastic anemia, MDS, PNH. My talk is about a stem cell transplantation approach for MDS, and hope you can hear and see the slides all right. Okay, so these are my disclosures, and my talk today will be mainly focused on how and we discuss and decide on patients with MDS about moving forward with allogeneic stem cell transplantation, and we'll touch upon, when it comes to transplants, what are the methods, types of donors, slightly different conditioning regimens that we talk to our patients, and so we'll try to cover those areas today. To start with allogeneic stem cell transplantation, so So this is the only potentially curative treatment for myelodysplastic syndrome. I think Dr. Osman's earlier discussion about non-transplant therapeutics, I think he covered a lot of promising treatments, effective treatments, but there are limitations, and that is where a transplantation is discussed. Now, this is very potent or strong because it can eliminate malignant hematopoietic clones, so those are the diseased MDS cells, and through a very strong chemoradiotherapy, which we deliver to patients prior to infusing stem cells. And the potentially more important factor is that this strong immune interaction between the donor's immune cells against MDS cells, that the donor's immune cells can actually fight and kill off any remaining MDS cells staying inside the patients. And then they can restore healthy blood cells from the stem cells of the donor. However, this procedure is associated with a very significant risks of complications, morbidities, and also mortalities too, such as complications called graft versus host disease, infections, toxicity to the organs from all these chemotherapies. Occasionally, the cells from the donor may fail to grow inside the body of the patient, which is not very common, but we'll discuss a little more details. Now, how it is done, I'm not going into too much detail here, but because some patients or many patients actually wonder when we say transplantation, it sounds like a surgical procedure, but it's not. It is really infusing cells, like transfusions of cells that contain stem cells coming from a donor. So the donor typically goes through a procedure called apheresis. So the blood goes through the machine takes out the stem cell fractions, and that fraction of the cells will be infused to the recipients after the recipient receives a form of chemotherapy, radiotherapy to essentially wipe out MDS cells. And the process. So this is not necessarily a treatment that we think about. It is really a process that kind of goes over inside the patient's body. Now, about a week before the infusion of the cells, we deliver chemotherapy or radiation therapy, again to number one, weaken the immune system of the patient so that they would not reject the donor's stem cells, and number two, to reduce and eliminate as much as possible about the MDS cells inside the body. And then the cells will be infused. We call it the day zero, and we kind of put the calendar from it, day minus 7, 8, day plus whatever. And in the beginning, the body will be going through this kind of immune processes. That the cells of the stem cells from the donor have to start producing white cells, red cells, and platelets, and start to also recover the immune function. The number of the cells may come back, but the functions take a long time, and during the course, this donor's immune system, even when we try to match the immune molecules called HLA, human leukocyte antigens, there is almost always some form of immune interactions which can cause a complication called graft versus host disease, and we try to prevent it using medications or manipulates the cell components within the graft. It happens we treat with prednisone and other medications. And again, the immune system of the donor takes many months to really build up strength inside the body of the patients. So we have to often use preventive antibiotics and start to re-immunize those patients later on. So this is kind of basics. Now, in order for us to offer stem cell transplant, I mean, we really have to know about MDS, and many speakers today, and you probably heard from different conferences too, that the myelodysplastic syndrome is relatively difficult concept. And what I tell my patients is that it is still to this date called syndrome, and it's not a single disease entity, just like we heard from PNH talk from Dr. Parker. Admittedly, we use syndrome when we don't really know what it is. However, to make it to a syndrome, you have to have shared features. So, okay, actually. Sorry, okay, here you go. It's characterized by ineffective hematopoiesis, meaning blood cancer low in varying degrees, and the cells have to be dysplastic, meaning again the shapes and size are not normal. And this is biologically based upon an expansion of malignant clone, so that kind of overlaps with other cancer type diseases, and that is a basis for this diagnosis, which can progress into acute leukemia, which is more aggressive form of cancer of the white cells. Now, the issues that we have to deal with is essentially low blood counts, which can make people sick, and the progression into acute leukemias. I just repeating the components of this syndrome, the cancer type biology behind, low blood counts, dysplastic appearance. I'm showing this just because you may be hearing some of the nomenclatures which may or may not make much sense to patients. These are the more like concepts that are kind of being introduced over the last some years as we learn, we know more about mutations and so forth. This is my focus of the topic, but just to kind of give you a sense of a spectrum of this diagnosis that can span from more like aplastic anemia type, low blood counts without dysplastic morphology, low risk for transforming into leukemia, towards more sort of leukemia-like MDS. And this diagram kind of fit very well to explain, what these names fit into for each kind of overlapping situations. I'm going to just touch briefly about the biologic basis or genetic basis. And again, we heard from earlier speakers today about the importance of genetics, chromosomes. So the chromosome is a structure of the genetic package that each cell has. And in MDS, there have been recurring the common mutation, not the mutations, chromosome abnormalities. It's shown here, but about 40% has the normal chromosome. Whereas if we look down to more detailed DNA level changes in genetics, virtually most of them have detectable mutations with kind of different kind of categories of the genes involved. The important point is that some of the genes have prognostic importance, implications. And this is just one of a few ARIA studies looking at the high-risk mutations they identified from this analysis, and having one of the high-risk mutations kind of upgrade the clinical grading of, or not the grading, but the prognostic categories of MDS. So if you have a low risk but has one of the mutations, your prognosis tends to behave more like intermediate 1 as opposed to low. So kind of 1 rank higher risk. So this was one of the first studies showing the impact of mutations. And now when we heard about these prognostic risks that originally developed in 1990s using very simple, low blood counts, chromosome, percentage of the blast. So again, kind of going back to the triad to make this diagnosis, low blood counts, sort of biology or genetics, and how the bone marrow looks inside the bone marrow all kind of contributes to understanding of their aggressiveness or difficulty in treating these conditions, which was reversed. And the last year, the analysis came in to incorporate that mutation landscape into the clinical prognostic variables, and so-called came up with IPSS-M. There's a tool for each of us can log on to type in the informations and give us some ideas. But again, we heard from Dr. Osman Arias' lecture that this is a statistics. That doesn't mean that you have to follow the fate of this. And another clarification is that these are the time when there was no effective treatment. So basically, this talks about the natural history of it when patients are just supported with transfusions in general. The first drug that did improve that natural prognosis or natural cause was Videsa, azacitidine, and in the United States and Europe, both demonstrated the improvement of patients surviving with the azacitidine as opposed to other chemotherapy drugs or supportive care, erythropoietins, etc. But what we can see is that the effect, the improvement is not quite permanent, and if anything, the life expectancies, improved, but probably up to somewhere between a year or two in many of these patients. I kind of summarize some of these large studies that compared either azacitidine or decitabine against best supportive care. And if you look at the 3-year, 2-year survival rates in these patients, still it is ranging only around 20–30%, so nowhere near perfect. Especially those who received Videsa, Dacogen, and then lost the improvement, their prognosis is extremely poor. However, you could see a little hint among those patients who were well enough and had the donor available, able to move on to transplants, did relatively better than the rest of the group. So going back to how the stem cell transplant is used in this disease, the number of transplantation for MDS is really increasing over the last decade, or in all age groups, but especially for the age group of 40 to 64 in orange line and 65 above. this is really the population that are affected by MDS, and transplant is more and more performed. This is a data not just MDS, but again, for any diseases, leukemias, lymphomas, all combined, we have been able to offer stem cell transplantation to advanced stage group nowadays. And the results are also, slightly, it's not a huge improvement, but stepwise we have seen, and we are trying to make the success rates better and better. And there are many reasons for this, and I'll get back to this later on. Now, City of Hope, my institution, offers a conference in Las Vegas every year, which have been on hold during the pandemic. But when we talk about the stem cell transplant, which comes with a very high risk itself, we feel like dealing with the dealer, which has a very strong card, that we have to offer something strong. And if you have 16, it's a dilemma that it's very easy to go bust, but statistically speaking, not as a gamble, actually. Mathematically, you have a better chance by hitting additional card. Now, there have been mathematical models in MDS about how the transplant improves the odds of successful treatment or survival. And this was one of the first by Dr. Cutler and others with different kind of clinical conditions and mathematical models, which is demonstrating in the previous IPSS categories. For those who are at the high risk or intermediate to risk, the early transplant is beneficial and reduce the risk of mortality. And this was for younger adults, and only with sibling donor transplant, the data from 2004. The update analysis for those patients who are aged 60 to 70 also demonstrated very similar results, that for the IPSS intermediate to or high risk patients, the chance of survival was clearly improved with stem cell transplantation. Coming to also some sort of health policy items, where actually this foundation, Aplastic Anemia MDS International Foundation, has been a strong advocate and has helped as well. But about 10 years ago, 2010, the Center for Medicare and Medicaid Services, actually, the field asked for them to cover transplantation for their beneficiaries. But they found the evidence not sufficient to do so. But they agreed to cover all the transplant requests as long as those patients are enrolled onto trials or studies that can address their questions, the information that they need. The one is to compare, the outcomes between transplant and non-transplant, and we did develop a protocol to address that, and I'll talk about this in a minute. And also, they wanted to gather lots of information and compare the outcomes between different variables, age, comorbidities, IPSS, etc. And it's more like a data collection study which CIBMTL has been running to this date. And this CIBMTL database did clearly demonstrate no difference in outcomes when the transplant results are compared between those who are aged at 55 to 64 versus 65 above. In terms of comparing the efficacy of treatments between transplant versus no transplant, in a prospective and randomized fashion is extremely difficult. Scientifically, speaking, you really have to be ready to go for transplant after finding a donor. You're ready to move, and you have to coin flip, and half the people go to transplant and half the people stop moving forward. And that's really not practical, and even considered maybe not ethical. That the ways that researchers conducted was a so-called biologic assignment. So back in time, the transplant was not successfully done when we have no matched donors. So we have a way to compare patients between those who had the matched donor, thereby they could go for transplant, versus patients with MDS that we thought transplant candidates and indicated, but we could not find a good matched donor that we could not move forward. And that way you don't have a biased selection and compare the outcomes between the two groups. So we call it the donor versus no donor studies. And the first of such was done in France, and did show separations or improvements after about 2 years or so. And there is a study by a German group which also demonstrated that those who are started with the Vidasa, it's called the Vidasa Arrow study, started with Vidasa, and those who found a donor who received transplant, they don't have a donor, continue with Vidasa, and the chance of surviving was better for people who had the donor identified. And in the United States, again, this was also in response to this CMS, the Center for Medicare and Medicaid Services. We did develop this not the randomized, but biologic assignment study between donor versus no donor, and similarly demonstrated after 3 years the chance of patients being alive. If you have a donor, you reach around 50%. Without, only about half of that patients are still alive. And this beneficial effect was seen across different categories of patient groups, like in the IPSS high risk or very high risk, or more importantly, actually, both patients who are older than 65 and less than or younger than 65, the having a donor had clearly improved the chance of survival. This effect corresponds also to the leukemia-free survival. So these are the patients who survive without progressing into leukemia. And we did also look at the quality of life measurements, because there are some concerns that the stem cell transplant can be more toxic. Patients may be feeling more poorly, and they may have long time to recuperate from. But when we looked at the patient-reported quality of life measures, essentially all the measurements are the same. If anything, actually, transplant group had a little better readout on some of these scores at a couple of different time points. So in conclusion, among all these studies, the patient, older adults, having a donor improved outcomes, and also this good effect didn't matter whether the patients were 65 or younger versus older. No decrease in quality of life measures. The message that we think we wanted to send out was that the transplant should be part of the discussion. It doesn't have to be offered to everyone. Of course, but it have to be, we think, it's part of the discussion items as a potential option, in consultation with physicians and transplant specialists for MDS. So again, advocating for early referrals to transplant centers. We kind of talked about the somatic mutations, genetic mutations. We know some of the mutations have a very poor prognosis even with transplantation, but still, despite that, the difference between transplant versus non-transplant holds that for those who are fit and have a donor and be able to proceed with the transplantation, regardless of the genetic mutations, the benefit seems to be present. Because there are some studies showing very poor prognosis MDS. The outcome after transplant is poor. That maybe we shouldn't even bother doing it. So that's one kind of argument sometimes we hear, and it's important discussion that if the chance is low, it's not like we recommend everyone to proceed. Again, because it's a very heavy duty burden for both patients and families. Some of the studies are showing very promising results, and so this is our institution's study looking at therapy-related MDS. So MDS happened after previous exposures to chemotherapy, which tends to have a poor prognosis, but after transplant, there was no really difference. And this difference was also, no difference was also irrespective of the patient having had so-called high-risk mutations. Still, the results seems to be hold good. That the transplant is a very promising and effective therapy in many of these patients. I'll briefly talk about how to transplant, and again, this is not meant to go too technical, but the first step for stem cell transplantation is to find a donor. And again, technology is now allowing us to do a transplantation more successfully from a donor who is not very well matched. When we say match, it is an immunologic match, and it's not like a blood type match. And we care about the molecules called HLA. Those are the proteins that kind of determine the immune system of the individual. And the better the match, the better the outcome in general. Again, more recently, it's been changing. But earlier studies did clearly show when we have a matched related donor, the outcome was the best. Matched unrelated donor, second. Mismatched unrelated donor, not as good. But again, this still remains a curative option for many of the patients. Haploidentical relative means that these are the half-matched family members. So if the patient has a son, daughter, those would be a guaranteed half-match, sharing one set of the genes from the patient and the one from the spouse. The results of such a transplant is getting better using so-called post-transplant cyclophosphamide, one of the ways to prevent graft versus host disease. And so in a graph in the right side, there's a little higher relapse, a little less relapse-free survival, but overall survival are very comparable. So again, in the recent years, I say maybe for the last few years to 5 years, this type of transplant has really been increased. We also talk about how to prep the patients before infusion of the cells, and there are so many different combinations of chemotherapies, maybe radiation for MDS. And the younger patients, it's been shown that the higher intensity tends to give us better results. Lower intensity transplant tends to be safer, but have a trade-off with a higher risk of MDS coming back after transplantation. And the right kind of balance of the intensity with curability, efficacy against MDS, and minimizing the toxicity and the risk of complication-related death. The balance is always delicate, and that's where transplant specialists and institutions, programs can help discuss with you. The one right side is one of the examples of within reduced intensity conditioning, so-called. There is also a slightly different nuance in terms of the strengths, and that's simply saying that the relapse and non-relapse mortality. So these are the deaths due to complications are higher with a little more intensive ones, but relapse rate is better with that regimen. So there is always some trade-offs that we have to be aware of. And now to do so, we use some of the metrics to estimate and predict how well, how resilient, how strong the patients are, so that we can titrate up or down on the intensity of the chemotherapy. And so-called HCT, or stem cell transplant comorbidity index, has been used to risk stratify those patients. And now with the advance in age, as we shared with you, it's becoming more and more important that we look into more functional status of those individuals, not just the age alone. It can actually predict how fast they walk, what the grip strength are. There are some metrics and testings that we can do to assess the functionality of aging populations, and we know that also help us inform the better or more personalized approach in terms of stem cell transplantation. And there are lots of still research and efforts going on. The balance between transplant and non-transplant can easily change, as you can imagine, if non-transplant therapeutics gets much better than transplant therapy, and vice versa. To be honest, I think both transplant treatments and non-transplant drug therapy are making progress simultaneous, but again, we have to kind of follow what's new in both areas to make the informed decision about transplant or no transplant. We talked about improved risk assessment, and we have to improve the transplant strategies, medications. We have a number of drugs that could be potentially used as a maintenance treatment after transplant, because some of them are not very toxic, and also ways to improve immune recovery, reduce graft versus host disease. So this is a kind of a summary slide that I wanted to share what kind of we think about when we talk about transplantation. So we have to understand the risk of MDS. What happens if we don't do transplant, and what happens if we do transplant, and the risk. So you don't. So there are some patients with MDS that can be okay, with just observation sometimes, or erythropoietin alone. Some of the low-risk patients, we do expect they will do fine for many years, and those are the people that we would not risk with transplantation, but clinical high risk, symptomatics with a very low blood counts, and now we know the genetic mutations can also give us an idea about how advanced the MDS may be. And if the MDS is advanced enough that we should act on, at least think about, we would recommend to have a conversation about the transplant, and often start looking for a donor. As we mentioned, the risk of complication will be less in people who are healthier and more active. And I can share a few of my patients that, when they came to me, oxygen dependence, previous smokings, not really quite, safe. I did not feel safe to offer transplant, but as they got the treatment with Bidesa and improved their blood counts, and they started exercise, now no longer needing oxygen, and when we test them with the lung test and heart test, everything, they pass, and successfully we could take them to transplant. So it is not one snapshot assessment. It is a dynamic process too, that the patient's condition change over time, so as MDS itself. So that depends on the risk of MDS changes, depends on the risk or fitness of the patient's change. The conversation kind of have to continue on a regular basis to that kind of take us to the timing of transplant too, which we don't necessarily know when the optimal time to move to transplant. But we always try to find a window where their physical condition is the best, right? Anything that has to be fixed. I had one of my patient had a bad knee and couldn't exercise, and MDS wasn't so advanced, getting controlled with the drug. So we agreed that maybe we do the knee replacement surgery first and get some exercise done and come back for transplant, and that's how the transplant was done for that patient. So again, individually, there is a probably best time to do it. The problem is that we do not necessarily know what's waiting ahead of us, right? That if we decide to delay the transplants, MDS can progress despite the treatment. People can get sick from, say, catching infections, pneumonias, complications from the chemotherapy, that the risk of transplant, even when we are ready, may be higher. So we try, again, not to delay to the point that MDS get out of control or progress into leukemia, or people start to accumulate too much side effects. At the same time, MDS is a little different from like acute leukemia, which doesn't give us a much window. Many people with MDS do have some windows to optimize the condition both ways, MDS and their physical condition, medical conditions too. That it's not like we always push for transplant tomorrow or next week either. So that is a very individualized, nuanced conversation that we always do. And on the right side too, that non-transplant therapy, again, this depends on disease response. They might have to come back to transplant discussion as well. I think this was the last slide. So we appreciate really all of you, the foundation, but also audience, patients, families. You're really the partners and members of the treating team. Again, MDS is a it's a relatively sort of chronic disease compared to some other leukemias, and have to deal with for some time. Transplant is also a process, as I explained. It's not like a one-day procedure. The whole biologic and immunologic interactions are happening in the body over many weeks and many months, where the support is critical by the families, friends, societies, communities. This is a picture of a reunion that we do annually, again, to the pandemic, to invite, we usually have about 3,000-4,000 patients on campus, patients plus families together, and just have fun, music and food and so forth. At the same time, we are very cognizant about people who couldn't even be on this picture, and that there are lots of room that we still have to make a progress on. Again, thank you for your attention and participating in this seminar, and for the foundation for supporting such a great event. Thank you, and I'd be happy to answer any questions.
Do we have any in the room today? No, definitely. I have one question from one online patient who says, once a donor has been identified, how far in advance of the transplant can the donor stem cells be harvested and frozen?
Right, so I think that has two kind of questions. So one is about the process of holding a donor, and that, right, I assume this is probably from unrelated donors, but and the two is, right, biologic sort of effect of freezing down. So the stem cells, by definition, actually are very strong and surviving cells, and they function very well after freezing down. There have been no visible difference between frozen cells and fresh stem cells in general, and it can be frozen for years and years, 10 to 20 years. I mean, we can still find those cells viable and functional. A little nuance or caveat is that when we now had the COVID pandemic, where most of the stem cells from unrelated donors had to be secured and frozen first before we moved to transplant, because of the risk of donor catching COVID in the middle of transplants that the recipient cannot go back from. So in that large comparative studies, the results are slightly seems to be better with fresh stem cells. But again, that doesn't mean that we cannot use, or we have a big difference with frozen stem cells. Now, in general, if a donor is identified, it's a good to know, and the person was willing, available. We cannot hold the donor forever, and we don't usually just cryopreserve, freeze down the volunteer donor cells ahead due to the cost and medical issues for the donors, and so many reasons. So we only commit to asking the donation only when we are really ready and sure. But again, identifying a donor in the registry helps, because even after 6 months later, if we go back, those donors are usually still available to approach when we are ready.
Thank you. Dr. Nakamura, how does the physician decide where the stem cells or how they're harvested to be most effective for a patient? So, in other words, bone marrow versus peripheral blood. Is there a preference, and if so, under what circumstances for each?
Yes, thank you for the question. So what we need is essentially two components within the products. One is this hematopoietic stem cells that can give rise to neutrophils, platelets, and red cells. You need healthy cells. And the second is the immune cells that are coming from the donor and can again help build the immune system to fight infections and also fight MDS cancer cells. So the bone marrow graft, bone marrow cells, the difference, the technical difference is that when we harvest stem cells from the bone marrow directly, that's when we call it bone marrow graft, or bone marrow stem cells, or bone marrow transplant. When we harvest cells from the blood, that's often called blood stem cells, peripheral blood stem cells. The blood stem cells, the products tends to have more immune cells. So the difference is that the cells from the blood tends to have a benefit of anti-leukemia or anti-cancer power or kick against MDS. However, with a little trade-off, that the chronic form of graft versus source disease, which is again not necessarily dangerous, but it's one of the complications that can be a little higher, in a range of maybe 10% or so more. Generally speaking, for MDS, we prefer stem cells from the blood for the reasons of knocking down cancer-type cells, cleaning up the bone marrow. Whereas when we have patients with aplastic anemia, for example, that's not the cancer-type diagnosis. Bone marrow is already empty, or maybe some MDS categories, but more kind of closer towards aplastic anemia. One might make a case to use bone marrow graft, where you don't necessarily have to have like anti-leukemia, anti-cancer immune fight as much as we need for leukemias and MDS, if that answers the question.
Thank you. Our next question is you may have addressed this earlier, but the question is there a cutoff age for transplant?
That's a very good question. So we try not to ask patients' age, but it's in the medical record, so we have to see it. The short answer is no. But the practical answer is probably yes. That used to be like 55, 60, 20 years ago. By 10 years ago, we were pretty comfortable up to 70. I think for the last 5-10 years, 70-year-old above is routine. Last year in our institution, more than 20% of transplants were at the age of 70 or above. We are very careful to offer transplant in patients between 75 to 80 that again sort of reserve in their function again tends to be a little less. We still offer, and others do offer transplant to patients in their 80s a little bit, but again, you have to squeeze your voice a little bit, offer it. Extremely, untested area. What it is that, if you think about the driving a car, well, actually, if you think about like 110-year-old person driving a car on the highway, I think the person can drive okay as long as nothing happens around him or her. But something happens, some like a dog or cat jump onto the road. I think resiliency or responsiveness to the complication is much reduced. So, if 20-year-old kids get pneumonia, they bounce back pretty well. But 80-year-old, it's a very difficult task to do. So that would be my nuanced answer here.
Thank you so much. Any questions in the room for me? Okay, so we'll go to our next one online. The next one online is transplant only for high-risk MDS patients? And if not, when would a low-risk patient be considered for transplant?
Yeah, no, that's a great question, and it's a question to the field as well, and a question to the CMS coverage. Many studies focus on so-called high risk, so that's, I think, we have a good idea. Low risk, I think, I would say somebody who is needing a very frequent transfusions, maybe more so for platelets, but also red cells that are not improving. Transplant is more offered for high risk, but we can't just tell patients that, okay, you should be living on transfusion for the rest of the life. So again, with the understanding, consenting agreements, I think transfusion-dependent, low-risk MDS patients, after some other treatments tried, I think could be a good candidate. Now, genetically or clinically, we know, for example, people with therapy-related MDS, so people who had a previous cancer, chemotherapy, and developed MDS, or MDS with very high-risk molecular markers, even though clinical prognostic variables are low risk. I think those are probably again, may not be urgent transplant, but the transplant, I think, is considered and discussed, and some of the patients and physicians agreed to proceed.
Thank you. And that's all the questions that we have. So I'm going to let Lauren finish the session. Thank you.
Thank you.
Thank you so much, Dr. Nakamura, for sharing your time and expertise with us today. If you would like to watch this session again at a later time, it will be available on the conference platform in the next hour by accessing the session and clicking on replay, or by navigating the on-demand tab in the platform hub. If we were not able to answer your question today, you can send it to us at any time in one of three ways. Send an email to help@amds.org, or call the AMDS IF helpline at 800-747-280, extension 2, or submit a question on our Facebook page at www.facebook.com/AAMDS. If you are watching online, please take a few minutes to complete the session survey. Your input is important to us and will help us plan future educational programming. Also, be sure to visit the exhibit hall and chat with the conference sponsors. The next educational sessions will start in approximately 15 minutes. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and for making us your resource of choice for information on bone marrow failure diseases. The AAMDS IF Medical Advisory Board and team are here to help you and your family as we have for the last 40 years. This concludes our session.